Um, Now I'd like to move on to our next finalist, Dr. Victoria Sherman. Victoria is a speech-language pathologist as she completed her PhD in rehab sciences at the University of Toronto. Her clinical work guided her pursuit of research in stroke and dysphagia. She focused on bridging the gap in dysphagia practices between adult and pediatric stroke. Her research goals include early detection, standardized assessment protocols, and early intervention of dysphagia to improve patient care and health outcomes in the young stroke groups. Victoria hopes to continue her research program as a clinician scientist, but is currently focusing on caring for her baby who was born in April. So congratulations. Welcome, Victoria.
Hi, my name is Victoria Sherman, and today I will present on my doctoral research entitled Early Identification of Dysphagia Post-Pediatric Ischemic Stroke. Stroke is a leading cause of death across the lifespan and is in fact one of the top 10 causes of mortality in children. In children, stroke can happen anytime from 28 weeks gestation onwards up until 18 years, considered neonatal stroke within that first month of life and childhood stroke beyond. Ischemic stroke in children includes arterial ischemic stroke and cerebral sinovenous thrombosis, and is distinct from adults with regards to acute clinical presentation, risk factors, etiology, and short and long-term outcomes. And perinatal arterial ischemic stroke is a leading cause of hemiplegic cerebral palsy. There's been significant progress in understanding outcomes of pediatric stroke in the last 2 decades, with known outcomes to include cognitive, motor, and behavioral, for example. However, there has been limited work to date exploring speech pathology-related outcomes in pediatric stroke, including sensory motor outcomes like dysphagia. In adults, we know that there's a large proportion of patients with dysphagia, dysarthria, and aphasia, so swallowing difficulties, motor speech, and language impairment post-stroke. And these outcomes are known to coexist and can adversely affect short and long-term outcomes. In adults, the current practice for dysphagia is well established. It first begins with a bedside screening by a trained health professional, which identifies risk and initiates the necessary referrals to dysphagia experts for further assessment. Dysphagia practice is outlined in many stroke practice guidelines, including Canadian and American, and they endorse screening as a critical first step to early identification of dysphagia. There is still some work to be done in adults. Even though screening is currently recommended in guidelines, there has been inconsistency over the past decade, leaving the healthcare professional questioning the true health benefit. In children, there are no practice guidelines specifically guiding dysphagia practice post-stroke. And this leaves us questioning if there's no systematic identification of dysphagia early, no initial step of screening, are their kids being missed? So the aims of my doctoral research were to derive the benefit of dysphagia screening in adult stroke, improve our understanding of incidence and current assessment practices in pediatric stroke and dysphagia, first in the current published literature, and secondly within a single institution, and lastly to inform the development of a reliable and accurate pediatric dysphagia screening tool. We first asked, does dysphagia screening to stroke patients by a non-dysphagia expert reduce health-related complications compared to similar patients with no or relatively less rigorous early detection in adults? Following a Cochrane protocol, we identified 33 articles, 30 of which were unique, with different screening comparison groups. For example, no screening versus screening, late versus early, and informal versus formal. We found a significant protective health benefit. For our 4 outcomes, pneumonia, mortality, dependency, and length of hospital stay, across study types and groupings, the overall pooled estimates favored the experimental screening groups for all 4. As you can see, the pooled estimate on the left of the midline for pneumonia, mortality, dependency, and length of hospital stay. This benefit was consistently realized in that late versus early subgroup, showing that an earlier screen had a benefit on health. So given the differences between adult and pediatric stroke, we cannot assume that what is well known in adults applies to children. So through conduct of a systematic review, we asked, what is the reported incidence of dysphagia in the pediatric patient population with acute stroke or hemiplegic cerebral palsy? And of those, what is the reported incidence of poor health outcomes and caregiver burden? Again, Cochrane methodology was closely followed, yielding 5 articles, only 3 on stroke and 2 on hemiplegic cerebral palsy. And we found variable reported frequencies. So across the 3 stroke studies, one found dysphagia in 48.8% of their symptomatic neonatal population. One identified swallowing impairment in 88.6% of their childhood stroke group. And one identified feeding difficulties in 24% of their neonatal stroke group. No dysphagia assessment protocols were described across these 3. Of the 2 hemiplegic cerebral palsy studies, Moraro and colleagues used the Dysphagia Disorder Survey and the Dysphagia Management Staging Scale which is validated on individuals with developmental disabilities. And they identified mild dysphagia in 50% of their group. And the final study identified swallowing impairment in 35% of their group. Only Barkat-Messy and colleagues reported health outcomes and none reported caregiver burden. So realizing the paucity of evidence on dysphagia, we sought to explore this outcome further at our own center through retrospective chart review and database analysis over a 5-year period. We asked, what is the reported frequency of dysphagia? And we expanded to include oral motor dysfunction, motor speech and language impairment. What is the co-occurrence and potential predictors of these target impairments? And what is the reported frequency of caregiver burden? We stratified our analysis by age in keeping with practice, and we had 67 neonates. We identified how many patients received notations and assessments for each impairment. Notation was defined as any note by any health professional which could indicate potential presence or absence prior to the assessment by an expert. We looked at time from admission to first notation and assessment, and we found relatively timely mention. So for example, from admission to dysphagia notation, there was a median of 75 hours. We found swallowing impairment in 38.8%, feeding alone in 16.4%, and oral motor in 6%. Dysphagia, defined as feeding and or swallowing impairment, was also in 38.8%. And caregiver burden was identified in over 60% of neonates and their families. We had 106 children, and again, top left, you can see the notation and assessment counts. So for example, 69% of children had a note on dysphagia, and 55.7% received an assessment. We captured timing again for each impairment, which continued to show relatively timely capture. So for example, there was a notation on dysphagia within a median of 24 hours. We identified dysphagia in 40.6%, oral motor also in 40.6%, motor speech in 36.8%, and language in 31.1%. We found arterial ischemic stroke subtype as compared to cerebral sinovenous thrombosis and stroke severity to be associated with each target impairment, and caregiver burden was identified in over 50% of children and their families. Although we identified attentive informal surveillance with relatively timely capture, there was no initial formal screening step and no formal protocols used to identify and assess dysphagia. And again, this leaves us questioning potentially that patients are being missed, and also left us questioning, are these frequencies potentially even conservative? Now knowing the significant benefits of early identification in adult stroke, this led us to believe similar benefit could be realized in children. And this led me to my final dissertation study, which was to complete the initial steps to develop a standardized dysphagia screening tool. We asked, what are dysphagia assessment items endorsed by clinician experts to be included in the development and validation of this tool? This was a 2-phase study with item generation followed by item reduction. We generated an exhaustive list of all potential dysphagia assessment items from the literature and expert consultation, and we created a conceptual map to categorize these items. These were then populated into a survey format with questions regarding relevance and feasibility, and we included extra questions to guide whether swallowing trials should be administered in the screen. We had 57 complete responses from speech-language pathologists across the world who all worked across the pediatric age range in different settings. And based on survey responses, we ran item content validity indices to identify those items rated as the most relevant and feasible. An ICVI greater than or equal to 0.78 was deemed to keep, and we found 4 items, which included facial symmetry, salivary control, level of alertness, and choking. We identified clinical uncertainty on whether swallowing trials should be administered. 31 respondents endorsed administration of swallowing trials in the screen, of which 25 endorsed thin liquids, most commonly recommended by teaspoon or open cup. We conducted chi-square analysis to explore any differences in the endorsement of these swallowing trials across country, years of experience, and proportion of caseload, and we found no significant differences. So there remains the need for prospective administration for clinical feasibility, inter-rater reliability, and accuracy. So in summary, our meta-analysis confirmed the benefit of dysphagia in adult stroke. Our systematic review identified 3 studies on pediatric stroke and dysphagia with limited details on definition and assessment. Our database and chart review found that these target impairments existed in 30 to 40% of all pediatric stroke patients in the acute phase and were often overlapping. And our prospective survey identified dysphagia assessment items deemed relevant and feasible to move forward in the development of this tool. My overall vision is to build capacity within pediatric stroke and speech-language pathology with goals to improve early recognition, develop standardized assessment protocols to initiate early intervention, all with the overall goal to improve patient care and health outcomes for this unique young patient group. Some of my short-term goals include to assess the psychometric properties to continue the validation of this dysphagia screening tool, characterize short and long-term burden of dysphagia, and determine neuroanatomical predictors of impairments. Thank you very much for listening, and a huge thank you to my supervisory committee and for the clinical and research teams that helped to make this research possible throughout my PhD. Thank you.